Okay, so today we're going deep on something that's, well, pretty crucial: how our bodies react when things go wrong, specifically allergic reactions and shock.
Yeah, definitely important stuff. You guys sent over some super comprehensive material from a nursing course, CNUR 204, I think it was.
That's the one.
And it covers a ton from how our immune system normally works to the nitty-gritty of anaphylaxis and all the different types of shock, even touches on initial management, which is great. It's like a crash course in understanding these really intense situations.
Exactly. I mean, we all know these things can be life-threatening, but do we really understand what's happening in our bodies when they
Oh,
occur?
right, that's the thing. And that's what we're here to unpack today, to kind of pull out those key insights from these materials so everyone listening can get a clear picture, without getting lost in all the technical jargon.
Love it. So let's jump right in, shall we? First up, the immune system, our body's incredible defense force. And the notes break it down into three main
The
functions.
main jobs, yeah.
Starting with defense, which makes sense, right?
Oh,
It's all about protecting us from those nasty invaders, bacteria, viruses, all that.
it's like our internal army constantly on patrol, ready to fight off any threat.
Exactly. Then there's homeostasis, which is all about maintaining balance, keeping everything running smoothly. Think of it as the cleanup crew, removing damaged cells and keeping things tidy.
Makes sense, yeah.
And then we have surveillance, this constant monitoring system, scanning for anything out of the ordinary, any signs of trouble.
Like a built-in security system making sure everything's in check.
Exactly. So this immune system is pretty sophisticated, right? And at the heart of it all is the antigen, basically. Anything that can trigger an immune response.
Right, it's like the red flag that alerts the immune system, hey, there's something here that needs attention.
And then the material dives into the two main types of immunity we have: innate and acquired.
Innate immunity, that's what we're born with, our first line of defense. Like our skin acting as a barrier, our stomach acid killing bacteria, certain immune cells ready to jump into action immediately.
Yeah, that's the rapid response team, ready to go no matter what the threat is.
Exactly. It's quick, but not super specific. Then there's acquired immunity, the more specialized branch that develops over time.
This one learns and adapts, right?
Exactly. It's like building up a database of all the bad guys we've encountered. So there's active immunity, the long-lasting protection we get after an infection or vaccination. Like our body remembers that specific threat and knows how to fight it off next time.
Makes sense.
And then there's passive immunity, a quicker but more temporary fix, like when a newborn gets antibodies from their mother.
Ah, so that's why babies are somewhat protected, even though they haven't built up their own defenses yet.
Exactly. Now, one crucial concept here is immunocompetence.
Yeah.
This is when your immune system is doing its job perfectly. It can identify real threats, respond appropriately, but doesn't attack your own healthy cells. No friendly fire.
Got it.
And the material contrasts this with hypersensitivity, basically an overreaction of the immune system.
So instead of just taking care of business, it goes a little overboard.
Exactly. And this overreaction can cause some serious problems. It can lead to autoimmune diseases, where the body mistakenly attacks its own cells.
Like type 1 diabetes, rheumatoid arthritis, lupus.
Yeah, those are some examples. In those cases, the immune system is essentially fighting against itself, which is, well, not good.
Definitely not.
And then, of course, we have allergic reactions where the immune system goes into overdrive in response to things that are normally harmless, like pollen, pet dander, certain foods.
I definitely know a thing or two about those.
Right. So for our deep dive today, we'll really be focusing on those allergic reactions, especially type I, which are the anaphylactic reactions. These are what we call IgE-mediated reactions.
Okay, break that down for me.
Think of IgE as a specific type of antibody, and it plays a huge role in these allergic responses. What's fascinating is how the body prepares itself for this overreaction. The first time you're exposed to an allergen, you might not even have a strong reaction.
Yeah, sometimes it takes a while to develop an allergy.
Yeah. Exactly. But even without a noticeable reaction, the body starts producing these IgE antibodies.
Ah, sneaky.
Right. And these antibodies attach themselves to certain immune cells called mast cells. So now the body is primed, sensitized to that specific allergen. It's like setting a trap, waiting for the next encounter.
So next time you come across that allergen, boom, trap is sprung.
Exactly. And those mast cells, loaded with the specific IgE, release a bunch of powerful chemicals called mediators. The notes highlight histamine and SRSA, or leukotrienes, as the major players.
Okay, those names ring a bell. They're basically the bad guys in this whole allergic reaction story.
You could say that. So let's break down what they do. Histamine, it causes blood vessels to become more permeable.
Meaning?
Imagine your blood vessels getting leakier, fluids start seeping out, causing swelling, runny nose, hives, all those classic allergy symptoms.
Wow, that's why my eyes get puffy and my nose starts dripping.
Exactly. And histamine also constricts smooth muscles, which can tighten up airways, leading to difficulty breathing. And of course, it's responsible for that unbearable itching and sneezing.
It's like a triple whammy.
Then we have leukotrienes, or SRSA, as they used to be called. They're a bit slower to act than histamine, but their effects last longer.
Oh, so they're the ones that keep the misery going.
Pretty much. They also constrict the smooth muscles in the airways, contributing to wheezing and shortness of breath. It's like a prolonged squeeze, making it hard to get air in.
Oh, no thanks. The notes also mention a difference between local and systemic mediator release. What's that all about?
Good point. So local release, that's when the reaction is limited to a specific area. Say you touch something you're allergic to, you might get a rash just on that spot.
Okay, so it's contained.
Exactly. But systemic release, that's when these chemicals flood your entire bloodstream, affecting the whole body. That's what happens in severe reactions like anaphylaxis.
Right.
Right. And it's important to remember that allergies often have a genetic component. The notes talk about atopic reactions, those milder, often localized allergies like hay fever, asthma, eczema. And then there's also a genetic predisposition to anaphylaxis, those more severe body-wide reactions. So some people are just wired to be more susceptible to these things.
Makes sense. It's like some of us win the genetic lottery when it comes to allergies, while others not so much.
Right. And speaking of, the table on chemical mediators is really interesting. It lists histamine and leukotrienes, of course, but also prostaglandins, platelet activating factor, kinins, serotonin, and anaphylatoxins. It's fascinating to see how varied their sources are: mast cells, basophils, even byproducts of other immune processes.
So it's a whole team of troublemakers.
And the clinical manifestations they list really paint a picture of what's happening during an allergic reaction. Swelling, trouble breathing, hives, nausea, and in the worst cases, shock. It really highlights how this cascade of chemicals, while meant to protect us, can quickly become overwhelming and damaging if not controlled.
Okay, so all this leads us to the big one, anaphylaxis. The notes define it as a severe body-wide allergic reaction that can be triggered by injections, inhaling something, or even skin contact. And the key is that rapid systemic release of those mediators we talked about.
It's like hitting the panic button on the immune system.
And it happens so fast, right?
Yeah.
Often within minutes. That's what makes it so terrifying.
Absolutely. The pathophysiology map in the notes does a great job breaking it down step by step. You start with exposure to the allergen. Common culprits are foods like peanuts, shellfish, insect stings, medications, latex.
Yeah, those are the usual suspects.
Right. This triggers the immune system, specifically that binding of the allergen to those IgE antibodies on the mast cells and basophils. And bam, those cells release their chemical weapons: histamine, leukotrienes, prostaglandins.
All those chemicals we just talked about.
And then the chaos really starts. You get vasodilation, blood vessels widening, causing blood pressure to plummet, increased capillary permeability, leading to fluid leakage and swelling, especially angioedema, which can be deadly if it affects the airways.
So basically, your circulatory system is going haywire.
Exactly. And then you have bronchoconstriction, those airways tightening, making it hard to breathe. There's irritation of the mucous membranes and even smooth muscle contraction in the GI tract, leading to cramping and vomiting.
It's like a full body assault.
And the symptoms can range from those milder allergy things we're all familiar with: itchy skin, hives, swelling of the lips, tongue, face, runny nose, nausea, anxiety, to the really scary signs of anaphylaxis. Severe shortness of breath, wheezing, throat swelling, significant drop in blood pressure leading to shock, rapid and weak pulse, dizziness, fainting, loss of consciousness, and if not treated immediately, cardiac arrest or respiratory arrest.
It's a terrifying thought, and it all happens so quickly.
Which is why the notes stress the importance of immediate action. If you suspect someone's having an anaphylactic reaction, recognize the signs and call for help immediately. Don't wait. Every second counts.
While waiting for help to arrive, the notes mention constantly monitoring vital signs: blood pressure, heart rate, breathing rate, as well as their breathing effort, level of consciousness, and heart rhythm.
All crucial information to relay to the emergency responders.
And of course, ensuring a clear airway and giving oxygen, often at a high flow rate, is crucial. The material even talks about involving respiratory therapy and being prepared for advanced airway management like intubation or even a tracheostomy if the airway swells shut.
Absolutely. And medications are key here. Intramuscular epinephrine is the first-line treatment. Think of it as the antidote to that out-of-control immune response.
The EpiPen everyone talks about.
Exactly. Repeat doses might be needed while waiting for EMS. And sometimes, if the IM epinephrine isn't working well enough, they might use IV epinephrine.
Okay, that sounds serious.
It is. Bronchodilators, like salbutamol, can help open up those constricted airways, and antihistamines like diphenhydramine are given to try and block the effects of histamine. The notes also highlight the importance of isotonic IV fluids to support blood pressure and positioning the person lying down with their legs elevated to improve circulation. Keeping them warm is important too.
So it's a multi-pronged approach to try and stabilize the situation.
Exactly. And looking beyond the immediate crisis, the notes stress important things for anyone at risk of anaphylaxis. Avoiding the allergen, of course, wearing a medical alert bracelet, informing healthcare providers about the allergy, always carrying an epinephrine auto-injector, and knowing how to use it. Being prepared can literally be the difference between life and death.
It's all about being proactive and knowing what to do in case of an emergency. So from this intense world of allergic reactions, we move on to another critical condition shock. The notes define it as decreased blood flow to the body's tissues, leading to impaired cellular metabolism. Basically, the cells aren't getting enough oxygen and nutrients, and waste products start building up.
It's like a supply chain breakdown, but on a cellular level. And if it's not corrected quickly, it can lead to tissue damage, cell death, and ultimately be life-threatening.
So it's a serious situation no matter what the cause.
Absolutely. And the notes mention that the overall signs and symptoms of shock will become clearer as we delve into the different stages. But the basic process involves some kind of trigger. It could be significant blood loss, a weakened heart, severe infection, spinal cord injury, or, as we just discussed, a severe allergic reaction like anaphylaxis.
So lots of different things can set this cascade in motion.
Right. This trigger leads to inadequate tissue perfusion, forcing cells to switch from their normal energy production, which needs oxygen, to a less efficient method called anaerobic metabolism.
Basically, they're scrambling to keep going, but it's not sustainable.
Exactly. And this leads to a buildup of lactic acid and what we call metabolic acidosis.
Not good.
And this cellular dysfunction is a key step in the progression of shock. Cells start to swell, their membranes become leaky, and if this lack of oxygen and nutrients continues, the damage becomes irreversible.
It's like they're slowly being starved and poisoned at the same time.
That's a good way to put it. And ultimately, this damage leads to organ dysfunction as vital organs, brain, heart, kidneys, lungs, GI tract, don't get enough blood flow. This can then cascade into multi-organ failure.
So it's a downward spiral.
It can be. Now, the notes walk us through the clinical manifestations of shock in 3 main stages: early, progressive, and late. In the early stage, also called compensated shock, you might see someone becoming restless or anxious, maybe a slight drop in their blood pressure. Their heart rate will likely increase as the body tries to pump more blood, their skin might feel cool and look pale, their breathing rate might go up, the time it takes for blood to return to their nail beds after pressing on them, what we call capillary refill, might be delayed, and their urine output might decrease.
So the body is trying to compensate for the problem, but it's still early stages.
Exactly. Now, if the underlying issue isn't addressed, the shock progresses to the next stage, called decompensated shock. Those initial compensatory mechanisms start to fail.
So things are getting worse.
Yeah. You'll likely see a more significant drop in blood pressure, the pulse might become weak and thready, the person might become confused or disoriented, their skin will likely feel cold and clammy, their breathing will be rapid and shallow, their urine output will be very low, and their blood lactic acid levels will keep rising.
And the final stage, the late stage.
That's also called irreversible shock. This is when things become critical. You'll see severely low blood pressure, the heart rate might slow down drastically or become irregular, the person might become unresponsive or even slip into a coma, multiple organs will start to fail, there will be little to no urine output, and tragically, if the shock isn't reversed, death can occur.
So it's a race against time to intervene.
Absolutely. The image summarizing the symptoms of shock really reinforces these points. It shows how these symptoms are essentially the body's last-ditch efforts to maintain vital functions when blood flow is compromised. Key things to look for are changes in mental state, rapid breathing and heart rate, low blood pressure, cool and clammy skin, and reduced urine output.
And then we have the table of lab results in shock, which gives even more insight into what's happening internally. For instance, high lactate levels indicate that cells are resorting to that less efficient anaerobic metabolism because they're not getting enough oxygen.
Right. It's like a red flag that the body is struggling.
And then there are changes in arterial blood gases initially. You might see a drop in carbon dioxide levels due to rapid breathing, which can then shift to metabolic acidosis as lactic acid builds up. A rising creatinine level points to kidney dysfunction due to reduced blood flow. Elevated CK levels suggest cellular damage is occurring. Even blood glucose levels can fluctuate, initially rising due to the stress response and later potentially falling as the body's energy stores are depleted.
It's like a domino effect with each organ system starting to malfunction.
And changes in liver enzymes and electrolytes like potassium and sodium can provide further clues about the progression of shock. The DIC screen results can indicate problems with blood clotting, which can also occur in severe shock. It's a lot of information, but it helps paint a complete picture of what's happening inside the body during shock.
Absolutely. And this understanding of the general principles of shock then leads us to the four main categories: distributive, hypovolemic, cardiogenic, and obstructive shock. The image in the material really helps to visualize these as distinct types.
Okay, so let's break those down. First up, distributive shock. What's the key feature here?
The main problem isn't necessarily a lack of blood volume, but rather that the blood isn't being distributed effectively throughout the body. This is due to a widespread dilation of the peripheral blood vessels. Imagine your blood vessels as a network of pipes. In distributive shock, those pipes suddenly become much wider, so the same amount of blood now has much less pressure behind it.
So it's not about the quantity of blood, but where it's going, or rather, not going.
Precisely. And as we discussed earlier, anaphylactic shock is a classic example of this. The massive release of those inflammatory mediators causes this systemic vasodilation. The notes also remind us of the risk factors like age, pre-existing conditions like asthma, COPD, and cardiovascular disease, and other signs and symptoms beyond the drop in blood pressure, like shortness of breath, that high-pitched breathing sound called stridor, swelling in the larynx and epiglottis, runny nose, flushed and itchy skin, metallic taste in the mouth, GI symptoms, and that overwhelming feeling of impending doom.
It's like your body screaming for help.
Yeah, it's a pretty dramatic response. Then there's neurogenic shock, which can happen after a spinal cord injury, spinal anesthesia, or a severe brain injury. The disruption of the sympathetic nervous system, which normally helps regulate blood vessel tone, leads to this vasodilation and low blood pressure. But what's interesting is that, unlike other types of shock, neurogenic shock often presents with a slow heart rate, or bradycardia, and the skin might feel warm and dry.
So it's kind of the odd one out.
In a way, yes. And then there's septic shock, another really serious form of distributive shock. It's triggered by the body's overwhelming response to an infection, leading to a life-threatening condition called sepsis. The notes provide a detailed table outlining the diagnostic criteria for sepsis, which involves an infection along with signs of organ dysfunction, inflammation, and problems with blood pressure and tissue perfusion. Septic shock is essentially the worst-case scenario, where the blood pressure drops dangerously low and doesn't improve with fluid administration.
So it's like sepsis on overdrive.
Exactly. Other common signs are fever or even abnormally low body temperature, rapid heart rate and breathing, confusion, and later on, cold and mottled skin. The pathophysiology diagram really illustrates how invading microorganisms trigger the release of a flood of inflammatory substances called cytokines. These cytokines damage the lining of blood vessels, activate the nervous and endocrine systems, and ultimately lead to widespread vasodilation, increased leakiness of blood vessels, formation of tiny blood clots, and a misdistribution of blood volume. The end result: a critical decrease in oxygen delivery to the cells and impaired metabolism.
It's like a systemic inflammatory firestorm.
That's a good analogy. Okay, moving on to hypovolemic shock. This one is a bit more straightforward. The core problem is a lack of fluid volume in the blood vessels. The notes differentiate between absolute hypovolemia, where there's actual fluid loss from the body, like through bleeding, severe vomiting or diarrhea, or excessive urination, and relative hypovolemia, where the fluid is still in the body but it's shifted out of the blood vessels into the surrounding tissues. This can happen due to increased capillary permeability or internal injuries.
So it's either a fluid deficit or a fluid maldistribution problem.
Exactly. Other signs might include delayed capillary refill and low red blood cell count, hemoglobin, and hematocrit levels in blood tests.
Okay, makes sense. Now, what about cardiogenic shock?
Cardiogenic shock is all about the heart's inability to pump blood effectively.
So it's a pump failure problem.
You got it. And this can be due to systolic dysfunction, meaning the heart muscle can't contract forcefully enough, often caused by things like a heart attack, cardiomyopathy, or severe high blood pressure. Or it could be due to diastolic dysfunction, meaning the heart can't fill properly with blood, which can be caused by conditions like cardiac tamponade or thickening of the heart muscle. Cardiogenic shock has a very high mortality rate because, well, your heart is essential for survival.
Definitely not something to mess around with.
No kidding.
Yeah.
Other signs you might see include decreased capillary refill, crackling sounds in the lungs from fluid backup, pale or bluish skin, fluid retention, decreased bowel sounds, nausea and vomiting, and elevated levels of cardiac enzymes in the blood, like CK and troponin, as well as increased BNP and BUN.
So it's a combination of heart failure signs and general shock symptoms.
Exactly. And finally, we have obstructive shock, which occurs when there's a physical blockage to blood flow, preventing the ventricles from filling properly, especially the right ventricle.
So it's like a traffic jam in the circulatory system.
Yeah, good analogy. The notes list specific causes like cardiac tamponade, tension pneumothorax, superior vena cava syndrome, abdominal compartment syndrome, and pulmonary embolism. Basically, anything that compresses or blocks those major blood vessels can lead to obstructive shock.
Wow. That's a lot of potential culprits.
It is. And the basic problem is that this blockage prevents blood from returning to or leaving the heart effectively, so the heart can't fill and pump properly, leading to decreased cardiac output, insufficient oxygen delivery, and ultimately organ failure.
And the signs and symptoms.
Similar to other types of shock: low blood pressure, rapid heart rate, weak or absent pulses, shortness of breath, chest pain or pressure. But there might also be specific signs related to the cause of the obstruction. For example, in tension pneumothorax, you might see a shifted trachea or decreased breath sounds on one side of the chest. In other cases, you might see distended neck veins.
So it's crucial to pay attention to those subtle clues to figure out what's causing the obstruction.
Absolutely. Now, the notes also briefly touch on the diagnostic studies used to identify and manage all types of shock.
Like what?
A thorough physical assessment reviewing the patient's medical history, continuous monitoring of oxygen saturation levels, an ECG to check heart function, chest x-rays or CT scans to look for underlying causes, sometimes even invasive hemodynamic monitoring to directly measure blood pressure and flow within the heart and major vessels, and of course various blood tests and urine analysis to evaluate organ function and metabolic status.
So it's a multi-pronged approach to gather information and guide treatment decisions.
Exactly. Now let's talk about the stages of shock, which really illustrate how this condition can worsen if the underlying cause isn't addressed. The notes describe 4 distinct stages: initial, compensatory, progressive, and refractory.
Okay, walk me through those.
So the initial stage is when the body is just beginning to experience a lack of oxygen at the cellular level. Cells switch to that less efficient anaerobic metabolism and produce more lactic acid. What's interesting is that at this early point, there might not be any obvious outward signs, but a blood test could show an elevated lactate level.
So it's a silent but deadly situation.
In a way, yes. Then comes the compensatory stage, where the body kicks in its defense mechanisms. The sympathetic nervous system gets activated due to the falling blood pressure, leading to increased heart rate and constriction of blood vessels in an attempt to shunt blood to the most vital organs like the brain and heart. Blood flow is diverted away from less critical organs like the kidneys, which then activate the RAS system to try and increase blood pressure and cardiac output. The good news is that at this stage, with timely and appropriate treatment, the shock can often be reversed.
So there's still a chance to turn things around.
Exactly. And some outward signs you might see include restlessness, confusion, a faster heart rate, a slight drop in blood pressure, rapid breathing, and cool, pale, or even flushed skin.
So it's subtle, but there are clues if you know what to look for.
Absolutely. Now, if the problem isn't corrected, the body moves into the progressive stage. This is where those initial compensatory mechanisms start to fail. Cellular perfusion continues to worsen, and the tiny blood vessels become more permeable, leading to fluid and protein leakage into the surrounding tissues. This further reduces blood flow to organs and tissues, and aggressive medical intervention is crucial at this point.
So it's a critical turning point.
Yes, the clinical signs become much more pronounced. The person might become less responsive, delirious, their blood pressure will continue to drop, their pulse will be weak and rapid, their breathing will be rapid and shallow, and you might hear crackling sounds in their lungs as fluid accumulates. Their urine output will be very low, and you'll start to see signs of organ dysfunction.
It's like the body's starting to shut down.
And finally, we reach the refractory stage. At this point, the body is overwhelmed, multiple organs are failing, and the anaerobic metabolism continues to worsen despite medical interventions. The increased permeability of the capillaries leads to even more fluid loss from the blood vessels, which further decreases blood pressure and blood flow to the heart and brain. There's severe hypoxemia, meaning very low blood oxygen levels, and dangerously low blood pressure, along with a buildup of waste products in the body. Sadly, recovery at this stage is very unlikely.
So it's a very grim prognosis.
Unfortunately, yes. Some outward signs might include unresponsiveness, loss of reflexes, fixed and dilated pupils, a very slow or irregular heart rate, complete respiratory failure, signs of an ischemic gut, meaning the intestines aren't getting enough blood, no urine output, evidence of liver dysfunction from the buildup of waste products, ongoing problems with blood clotting, and mottled cyanotic skin.
So essentially the body's on the verge of complete collapse.
That's a good way to put it. And the notes provide a helpful summary table comparing the 4 stages, highlighting the key features, blood pressure trends, heart rate changes, urine output, and mental status changes. It really illustrates that progressive decline if effective treatment isn't initiated.
Okay, so let's talk about managing shock. What the essential things to remember?
The notes really emphasize continuous, thorough assessments. You need to constantly monitor vital signs. Blood pressure, heart rate, breathing rate, oxygen saturation levels. Also assess their respiratory effort, heart rhythm, pulses, capillary refill in their extremities, their level of consciousness, urine output, and the condition of their skin, looking at temperature, color, and moisture.
It's like being a detective, constantly gathering clues to understand what's happening and how to intervene.
That's a great analogy. And then the notes break down management into 4 main areas.
What are those?
First, airway and breathing. Ensure a clear airway. Be prepared to assist their breathing with intubation and mechanical ventilation if needed. Provide high-flow oxygen, balance their activity level with their oxygen needs, and consider blood transfusions if there's been significant blood loss.
So it's all about optimizing oxygen delivery to the tissues.
Exactly. Second is circulation. Establish good IV access, offer 2 large-bore IVs or a central line, and begin fluid resuscitation, usually with crystalloid solutions like normal saline or lactated ringers. Sometimes hypertonic saline might be used, but you have to be careful with that and monitor electrolytes closely. Treat any heart rhythm problems, monitor lab values, insert a Foley catheter to track urine output, and especially in obstructive shock, address that underlying physical blockage.
So it's all about restoring adequate blood volume and flow.
Exactly. The third area is medication therapy. The notes list several sympathomimetic medications like dobutamine, epinephrine, norepinephrine, phenylephrine, and vasopressin. Each drug has a specific effect on heart rate, blood pressure, cardiac output, and blood vessel constriction or dilation. The choice of medication really depends on the type of shock and what the body needs at that moment. Other meds that might be used include nitroglycerin, hydrocortisone, bicarbonate, antibiotics for septic shock, and even opioid analgesics and benzodiazepines for pain and anxiety management.
So it's a complex pharmacological dance to try and restore balance.
And finally, the 4th area covers other essential interventions, like stabilizing the cervical spine if there's any concern about a neck injury, keeping the patient NTO until their condition stabilizes, using a nasogastric tube for suction if needed, watching for signs of gastrointestinal bleeding, assessing bowel sounds and abdominal distension, constantly checking lab results, doing passive range of motion exercises to prevent complications from immobility, potentially starting parenteral nutrition if the patient can't eat, monitoring temperature, doing regular skin assessments and repositioning to prevent pressure ulcers, maintaining meticulous hygiene, providing psychosocial support, and even being prepared to offer end-of-life care if the situation warrants it.
Yeah. It's a holistic approach to care, addressing not just the physical needs, but the emotional and psychological needs as well.
Absolutely. And the notes wrap up with some multiple choice questions that cover key concepts related to anaphylaxis and shock. It's a great way to test your knowledge and make sure you understand those critical distinctions and immediate actions.
It's always good to reinforce learning with a little quizzing, right?
Exactly. So, as we wrap up this deep dive, we've covered a lot of complex ground. We've explored the spectrum of allergic reactions, from those annoying sniffles to the life threatening crisis of anaphylaxis. We've delved into the dangerous world of shock, understanding how inadequate blood flow can trigger a cascade of events that can lead to organ failure and death. We've differentiated between the four main types of shock and traced their progression through those four distinct stages. And we've reviewed the fundamental principles of managing these critical conditions, highlighting the importance of rapid recognition, immediate intervention, and ongoing assessment.
It's definitely a lot to take in, but it's crucial information for anyone involved in healthcare. We're simply interested in understanding how the body responds to these kinds of threats.
Absolutely. And this brings me to a final thought-provoking question for you to ponder. How is it that seemingly different triggers like a severe food allergy versus a massive bacterial infection can lead to such similar life-threatening conditions like anaphylactic and septic shock? Both involve the release of powerful systemic mediators and necessitate rapid, decisive action. What are the fundamental principles that govern the body's response to such diverse threats, ultimately leading down these comparable critical pathways? It's a question that really highlights the interconnectedness of our body systems and the delicate balance required to maintain health.
Food for thought indeed. Thanks for joining us on this deep dive into the world of allergic reactions and shock. Until next time, stay curious, stay informed, and stay safe.